disclosure, my disasters are not disasters because since I graduated fellowship 1.5 years ago, I work in a sister hospital of Mount Sinai, smaller program. I don't get PAD patients referred, but I help my colleagues with their cases sometimes. And this is one of the complications I encountered when I was helping. So this is a 71-year-old female patient, and also full disclosure, I cannot keep up with the drama you guys presented already. This is very, very easy, straightforward, not even worse dimension. But typical risk factors: presents with claudication, right more than left. Ultrasound shows moderate CFA atherosclerosis and occluded right SFA and CF and left SFA as well. And this is here the initial angiogram obtained. As you can see here, there is a CTO on the right leg. Tibial vessels are quite good. And the colleague proceeds with CTO intervention with the typical technique with knuckle and glide wire. He does a true lumen cross. He deploys a filter, does a PTA with undersized balloons. The entire SFA segment up to the proximal part. He does a shockwave, and then he implants a stent in the distal segment. He does a DCB for the proximal part, and he takes a picture, and then he finds an occlusion of the profunda. And here where the situation becomes a little bit heated, call this, call that, vascular surgery, call. And one of the colleagues in the cath lab said, why don't you call Serdar, he just started. So I came to the room, and was, as mentioned, like a straightforward case. So if for recollection, this was the initial angiogram. And as you can see here, this dislodged thrombus or material was likely in the common femoral artery. But where is this next picture here? And with all the manipulations and devices which went in and out of the sheath, probably this atheroma got dislodged into the profunda and occluded it. So moving forward from there, we wired both arteries, profunda and SFA. I decided to put a new filter in to avoid any embolizations in the SFA. We did a mechanical thrombectomy with penumbra, and we did a kissing balloon, two undersized balloons in the profunda and SFA. Then we did an angiogram, looked good in the profunda segment, flow re-established, and we saw also dissections in the SFA, and the colleague decided that he wants to stent this, which we did at that moment. And this is the angiogram after stenting the proximal part of the SFA. Again, we lose the profunda. So back to action again. So we knew that mechanical thrombectomy worked quite well. So we went in and did that. Then we did PTA, and at that moment I suggested to my colleague that we probably manipulated too much in the profunda, and it's such an important vessel. So we used also a DCB in that segment. And this is the final result. And my colleague was unhappy, and I told him, I learned from my mentor that the enemy of better is, the enemy of good is better. And I said, let's keep a close eye on this patient, give him a dual antiplatelet and rivaroxaban for a month, and we'll see how he does. Patient was discharged next day, and the patient came for a follow-up angiogram for the left SFA intervention. And the colleague sent me this picture from an outpatient lab where he performed an access on the right side. And as you can see here, the intervention site is patent and also the profunda is patent. Still, there is atheroma there, which is probably already organized, but the result was quite good. And patient got bilateral intervention and hopefully is walking now.